Hello everyone, this is Dr. Krishan. Today we are having a nose case presentation. Basically, this video is for exam going PGs, also useful for UGs as well as the newly joined PG resident. Many newly joined PG, ENT PGs have requested me to make a video on how to make a case presentation of nose or how to make a file. They will get an idea. उनको idea होगा कि क्या क्या history elicit करनी होती है nose के case में. Commonly nose की surgeries होती है generally ENT hospitals में, like septoplasty, फेस एंड ऑल. तो एसी पॉलिप एंड ऑल की केसेस होते रहते हैं, तो उनके लिए क्या क्या हिस्ट्री लेना चाहिए. तो राइट फ्रॉम द बिगनिंग, जब से यू हैव ज्वाइन रेजिडेंसी, यू शुड फोकस ऑन दीज पॉइंट्स. सो यू विल बी इन अ हैबिट ऑफ हैविंग अ गुड केस presentation. Means you will be knowing what all cases, what all things are important to mention in the file. So starting with the case, uh, my patient is Surinder, who is 40-year-old male. He is mechanic by occupation and he is residence of Okhla, Delhi. So why the occupation is important? Because there are many sinonasal malignancies associated with wooden workers and also like that. So he presented with the chief complaint of left-sided nasal obstructions for 4 months, left-sided nasal discharge for 4 months, and swelling over the left cheek for 3 months. So after this, coming to the history of present illness, uh, the patient was apparently well. The patient was apparently well. The patient was apparently well 4 months back when he developed left-sided partial nasal obstructions, which was insidious in onset. Which was insidious in onset. Uh, 1 minute. Yeah. So coming to the history of present illness, coming to the history of present illness, the patient was apparently well 4 months back when he developed left-sided partial nasal obstruction, which was insidious in onset and gradually progressive and persistent in nature, which was relieved partially on topical medications. Generally, the patient used xylometazoline drops or they use the steroidal spray. Increased with episodes of cold, no diurnal variation or postural variations, no other aggravating or relieving factors. Patient doesn't complain of nasal obstruction on the right side. So जब भी nasal obstruction के cases आए तो हमें ये onset important होता है, जो onset duration, progression कैसा है. So if it is progressive or if it is progressive, then we can think of a malignancy. जो constant होता है, then we say it, the most common cause is deviated nasal septum. So the patient developed left-sided nasal discharge for 4 months, which was insidious in onset, progressed gradually. The discharge was intermittent. So discharge में हमें onset तो बताना ही बताना है, साथ साथ color is important. Yellowish in color, sticky inconsistency, non-blood stained, foul smelling, and could be sniffed back. The discharge increased with episodes of cold, no history, suggestive of increasing discharge in early morning or on bending forward. Relieved partially with oral and topical medications. There was no diurnal, seasonal, or postural variations. No other aggravating or relieving factors. So, what we see by there were no diurnal variations. So, generally, with the day, in case of allergic rhinitis, what happens, the patient, as soon as the patient goes out, if he is sensitive to this dust and all, then the rhinitis increases. So regarding the consistency, mucoid discharge is most commonly seen in the sinusitis, whereas if the discharge is watery, the common disease, the provisional disease we think of is allergic rhinitis or CSF rhinitis. If there is a stroke, trauma, or even in idiopathic, there are idiopathic cases of CSF rhinitis. No other aggravating and relieving factors. Patient doesn't complain of nasal discharge on the right side. So he's having unilateral disease. The patient also complained of left cheek swelling for 3 months, which was insidious in onset, initially about the size of 2 cross to approximately 2 cross. You have to always the size अप्रॉक्स लिखिए, इवन इफ यू हैव मेजर्ड ऑलवेज राइट अप्रॉक्स, क्योंकि जो ऊपर की स्वेलिंग है जो ही नहीं है वो अंदर की स्वेलिंग है, मतलब कि स्किन पे जो स्वेलिंग हमें ऐसे होती है इंट्रो वो स्वेलिंग नहीं होती, थोड़ा डिफरेंस होता है, ऑलवेज राइट अप्रॉक्स, size of approximately 2 cross 2 centimeter and gradually progress to the present size of about 5 cross 4 centimeter. जो अर्लियर हम यूज करते थे कन्वेंशंस की, पी इनिशियली द साइज ऑफ पी देन दैट ऑफ टेनिस बॉल, वो आजकल डिस्करेज किया जाता है, वो नहीं यूज करना चाहिए, that is not scientifically correct also. Swelling was initially associated with pain, continuous dull aching in nature, non-radiating and not referred elsewhere. Pain reduced after 5 days of onset. Swelling was not associated with the fever. Swelling self-drain, generally we rule out the tubercular history. Swelling self-drained through the skin painlessly 2 months back with continuous discharge, which was yellowish in color, sticky in consistency, non-bloody stent, foul smelling. No other aggravating or relieving factors present. Then there was history of post nasal discharge present due to patient used to do hawking. Hawking means history of bad breath present, history of headache and facial pain present, intermittently relieved by oral medications. No history of headache and facial present. There was no history of decreased altered sense of smell or inability to identify smells, anosmia or hyposmia. No history of decreased nasality of the speech, change in voice. No history of loss of sensations over the paresthesia, cheek or face. No history of visible mass protruding out of the nostril. No history of watering from eyes. There was no history of recurrent sneezing, cough, or cold. No history of snoring or frequent night awakenings. No history of double visions, blurring of vision, protrusion of eyeball, drooping of the eyelids. There was no history of loosening of the teeth. No history of trauma to nose or nasal bleed. No history of sleepiness during the daytime. No history of loss of weight or decreased appetite. No history of ear discharge, ear pain, or decreased hearing. No history of any neck swelling. So you should know the significance of it. Coming to the past history, the patient is in a known case of type 2 diabetes mellitus since 4 months, presently on oral hypoglycemics and insulin. No history of tuberculosis, hypertension, allergy. In granulomatous disease in TB, there is a septal perforation, that is one of the common disease of the nasal septum. So you should rule out the tuberculosis also. Hypertension, allergy, hypertension present with epistaxis, allergy, asthma, seizures, cardiovascular disorder, didn't undergo any major surgical or medical procedure in the past. In the negative history, it is also important, no history of bleeding from the nose like that. Why? Because that is also important to rule out the cause, as well as if there is a bleeding. We generally ask for the quantity of bleeding that is used to make diagnosis also, as in different conditions there is a different amount of bleeding, as well as in the management of the patient per se, whether if there is a blood loss of greater amount, then we have to replenish it with fluids or the colloids and plus blood transfusion. Coming to the family history, there is no family history of severe illness, no history of allergy or asthma. Coming to the personal history, patient is married, mechanic by occupation, belongs to lower middle class. Always mention here the as per modified Kupuswamy scale that we used to read in PSM. Patient follows mixed diet, the appetite is normal, the bowel bladder movement are normal. There is history of tobacco chewing since 15 years, 1 to 2 packets per day. So this is significant. It points towards the malignancy also. Treatment history of using topical nasal medications on and off for past 4 months in consultation with a local practitioner. Nature of which was not known to the patients. No known history of drug allergy. So coming to the general physical examinations, patient is conscious, oriented to time, place, and person. Pulse rate was 83 per minute, respiratory rate 17 per minute. Temperature is afebrile, blood pressure 132 by 74 millimeter of mercury. No pallor, cyanosis, icterus, clubbing, pedal edema, lymph node enlargement was noted. So coming to the systemic examinations, CVS. Coming to the cardiovascular examinations, S1, S2, audible, no murmurs or additional sounds heard. CNS, no gross sensory or motor deficit. Respiratory system, bilateral air entry equal, normal vesicular breath sound heard, no added sounds were heard. Per abdomen, soft, non-tender, no organomegaly noted. Generally, malignancies. Coming to the local examinations, so external nose, on inspection, there is no swelling, tenderness, deformity, deviations. Osteocartilaginous framework is normal in appearance. No scar, sinus, or erythema. Palpations, no tenderness, no local rise in temperature or nasal crepitus. Coming to the vestibule, bilateral vestibules examined, no pus point, furuncle, bleed, or erythema scenes. On palpation, there is no local rise of temperature or tenderness. On anterior rhinoscopy, patients was examined in a sitting position using appropriate size pre-warmed pudicums nasal speculum. Pudicums is held in the non-dominant head already. Left nasal cavity, septum appears midline and normal. Nasal cavity, crusts and discharge present, crust removed and discharge suctioned out. Always you have to write that you have to remove, you have removed crust and discharge is suctioned out. Middle terminates appear necrotic. Inferior turbinate appears normal. Floor and mucosa of the nasal cavity appears normal. Right nasal cavity, septum appears midline. Nasal cavity clear. Middle turbinate appears normal. Inferior turbinate appears normal. Floor and mucosa of the nasal cavity appears normal. So coming to the photograph of the nasal septum. This is the photograph. This is the middle turbinate. Middle turbinate is normal. Inferior turbinate normal. On the right side, left side septum in midline. Left middle turbinate appears necrotic. Crust present. Mucosa appears conjected. Inferior turbinate normal. No mass polyps in posterior pharyngeal clear. So coming to the posterior rhinoscopy, always in nose case do mention the posterior rhinoscopy. Bilateral guanal patency normal. Posterior end of the posterior rhinoscopy must be mentioned in the exam. In file, no need to make right posterior rhinoscopy. Nowadays we document diagnostic nasal endoscopy. So bilateral guanal patency normal. Posterior end of the nasal septum appears normal. Posterior end of left turbinate appears necrotic. Posterior ends of all other terminates on both sides appear normal. Bilateral torus tuberous eustachian tube opening and fossa of Rosenmuller appears normal. These three are the significant areas जहाँ पे हम nasopharyngeal CA या ये सब suspect करते हैं. So you have to document this bilateral torus tuberous eustachian tube opening and fossa of Rosenmuller. Fossa of Rosenmuller appears normal. No polyp or mass seen protruding into the nasopharynx. This is the posterior rhinoscopy photo. This is posterior end of septum appears normal. Left middle turbinate necrotic. Fossa of Rosenmuller, eustachian tube opening, torus tuberous, uvula, nasal turbinates. Functional test of nose. So cotton wool test, decrease movement of left side, cold spatula. You should know how to do this. We'll make a video on these also. So cold spatula test, decrease fogging on left side. Cotton's wool test, no improvement bilaterally. Sense of smell, normal response to clove while peppermint while coffee, and essence of rose on both sides. Examinations of paranasal sinus. Maxillary sinus inspections, diffuse swelling present over the left maxillary region with an ulcer of 2 × 1 × 0.5, approximately 2 × 1 × 0.5 centimeter in the infraorbital region, extending vertically from 1 centimeter inferior to inferior orbital rim to 1 centimeter inferiorly, and horizontal from 1 centimeter lateral to the apertures to 2 centimeter laterally. Ulcer has sloping edges, underlying bone exposed, and active purulent discharge present. No bleeding pus point seen.